Hi, my name is Chelsea Bristow, and today I'm going to be doing a lesson for heart failure and comparing ACE inhibitors to ARBs for the heart failure treatment patient. This is done for Advanced Pharmacology for the Nurse Educator class at UT Arlington. So we'll start off. This is a class designed for second semester nursing students in a BSN online program. So they'll be in their second process class pertaining to more critical care cardiac patients, and our heart failure and ACE ARB lesson will be a part of that. We're combining both patho and pharmacology into this lesson. We're going to implement a flipped classroom. So the students are going to come to class already knowing the pathophysiology of heart failure. We want them to have a really good grasp of this before coming to class. That way we can utilize our class to talk about medications, and then they'll be able to make things click in their mind because they're going to know the pathophysiology of heart failure already. So we can spend more time on medications, and we can use that to transfer didactic information into real life practice in our simulation activity. So in a normal heart, we'll just start with our normal healthy hearts. We know we have the arterial muscle, the venous muscle, and the excitatory muscle fibers. The right side of our heart gets unoxygenated blood, which takes it to the lungs where it gets oxygenated, takes it to the left side of the heart, which pumps out to the body. That's how a normal healthy heart works. So we know that in heart failure, our heart is not healthy. So it's chronic activation of the sympathetic nervous system causes heart failure, and with the sympathetic nervous system, our renin-angiotensin-aldosterone system is going to lead to progressive changes of the cardiac tissue, myocyte reduction, hypertrophy, and fibrosis. Some causes of heart failure include having a heart attack, volume overload, valvular regurgitation or stenosis, vascular hypertrophy, or pericardial disease. So any type of cardiac problems can lead to heart failure eventually. This is diagnosed with blood tests, chest x-ray, echocardiograms, which are going to show you your ejection fraction, and or a stress test. So that'll just kind of depend on what your doctor sees and what other comorbidities this patient has as to why. So we're going to look at our concept map that you should have turned in before class. This obviously is not an art competition, and if it was, I would lose. But I think it gets its point across. So you've got the enlarged left ventricle right there, which doesn't allow it to pump as well. This patient has the pulmonary edema, the peripheral edema, and you can see +4. He's short of breath. He has decreased cardiac output, which is hard to draw, but I tried. In a high sodium diet, he's enjoying a big piece of pepperoni pizza. And then the other aspect of our concept map was to put treatment options for this patient. So our ACE and ARB, they improve our cardiac output, and that's what we'll get to in just a minute. Diuretics are used to decrease edema, so it's going to decrease the work of the heart, get that extra fluid off our body, which the fluid causes major side effects like our pulmonary and peripheral edema, so we want that gone. This patient can be on a low sodium diet or water restriction, so they may only be able to have 1,000 mLs of fluid a day, 1,200, and that'll be up to your doctor. And then we need to think about what caused the heart failure. If it was, a heart attack, maybe we need to do a heart cath, or we might need an ICD with this patient. So we'll just have to figure out why they had the heart failure in the first place. So now we'll just go right into treatments. ACE inhibitors are the #1 treatment option for heart failure patients. At our hospital, it's actually a CMS indicator that ACE inhibitors have to be prescribed for any patient that has heart failure prior to discharge. And if there's doctors have to document a reason why not if they didn't. So it is a huge deal, and it's CMS supported, so we know that it's got the evidence to back it up. So our ACE inhibitors, or our angiotensin converting enzyme inhibitors, work by stopping the progression of angiotensin 1 to angiotensin 2. So it disrupts the cycle right there. This is going to decrease the angiotensin 2 in the body as well as the available aldosterone in the body. And therefore it's going to decrease our vascular constriction, vessels are going to dilate, we're going to have a lower blood pressure, and decrease the work of the heart, not having to push through those really small vessels. So the expected outcome, we want to decrease vascular resistance, which is going to be our afterload. We're going to decrease venous tone, which is our preload. will improve cardiac output and improve their quality of life by getting rid of some of these symptoms. These are very effective medications. The efficacy, these are the first-line treatment option, like I said, not only with heart failure, but with any patient who has hypertension and other cardiac comorbidities. So the safety. The most common side effect is a dry cough, which is not deadly, but very annoying. It can happen in about 10% of patients. Some dangerous side effects that you really need to educate your patient on would be angioedema, high potassium, so hyperkalemia, or low blood pressure. Any blood pressure medication we give has the potential to cause low blood pressure. And the side effects are going to worsen when paired with a diuretic. So if we're already lowering their blood pressure and then we're getting fluid off their body, it's going to worsen with the diuretic. So we need to watch for that. The cost, these are very attainable medications for our patients. They're run less than $10 a month. And so our patients are more likely to be compliant with these, which is a great resource for them. And then just some examples, you're going to get your Pril with the ACE inhibitor. So your Acupril, Lisinopril, Benzapril, Enalapril, Ramipril, and Quinapril. So those are our ACE inhibitors. And then our ARBs. So our angiotensin receptor blockers is our ARB. The mechanism of action with these is it blocks angiotensin 2 by becoming competitive for its receptor sites. So it's still going to, angiotensin 1 is going to convert to angiotensin 2, but it's not going to be able to be activated because there's not receptors available because the ARBs have taken over them. So the expected outcome is similar to our ACE inhibitors. It's going to produce arterial and venous dilation. It's going to block secretion of aldosterone as well, and it's going to decrease the blood pressure and decrease the sodium water retention in our body. Safety, this doesn't affect the angiotensin enzyme, which we've talked about, and so there's no bradykinin involvement. That's important because the bradykinin is what causes that most common side effect, the dry cough, and the angioedema with our ACE inhibitors. So these are great options for patients who couldn't handle the side effects of the ACE inhibitor. If they couldn't handle the dry cough or they have that angioedema once, these are great options for them. So cost, these are a little more expensive than your ACE inhibitors, depending on which one your doctor thinks you need. So you can get them for $16 a month, but they do range all the way to $71 a month. So you need to make sure your patient can afford the medication they're going home on, otherwise they're not going to take it. And so our ARBs are our sartans. So valsartan, cardisartan, losartan, irbesartan, telmisartan, and olmesartan are examples of these. So very similar, but there are some differences with our ACE inhibitors and our ARBs. There's no real environmental or genetic aspects of our ACE inhibitors or our ARBs when it comes to the heart failure patient. You just need to make sure you educate them on the side effects, and include with low blood pressure, you really need to educate them on fall risks as well. So other treatment options that we're going to provide for these patients are diuretics, which we've talked about. Those are water pills that are going to get that extra fluid off the body. It's going to ease your work of breathing, and it's going to get that swelling down. Beta blockers help to lower the blood pressure and improve cardiac output in patients, so those are another great option. And then sometimes they'll need an ICD, they'll need a CABG, they'll need a heart cath, they'll need different things to get rid of the reason the heart failure was caused in the first place. So, evaluations of what we've learned today. Our concept map will be used to evaluate whether the flipped classroom worked. We need to make sure they had a good understanding of heart failure prior to coming to class so they understand what the ACE and ARBs do. The pharmacological and other treatment options will be tested using a simulation activity. So after this lecture, which is nearly done, we're going to do a simulation activity online where they'll have a heart failure patient. They'll have to, compare the different pharmacological options. They're going to have to analyze the patho of their patient and the heart failure to see what's going on, what's needed, and then they're going to formulate a nursing intervention plan with the simulated heart failure patient. So those are objectives 2 through 4. Again, our concept map is helping us able to see if they were able to apply the knowledge they read. And then we're going to do a summative evaluation midterm for our cardiac exam. So that's all we've got. If you have any questions, comment below, and thank you for watching today. Thanks.